recording this session. So I just want everybody to know that I'm about to start recording. And that's so that we can post these sessions for your colleagues who are not able to be here today. So those are folks who may be on night rotations, might be off, etc. So we are going to post all of these. And I'll send out the link. Brian Valentine, our webmaster, is working on a site that can host these in a private way, like HIPAA protected. I see a couple of folks posting in the chat, so I will get back to you, and thank you for letting me know if anybody's having a hard time doing the QR code. Please let me know. I'm going to reshare it now. All right, so quick introduction to Intern Teaching Conference. This is a protected hour for your education for 8 weeks in a row this summer, and we've done this for years. And it's a really nice opportunity for us to bring everybody together early in the year. We know that you're all coming from different places and spaces, and I think especially this year, given everything that's been going on in the spring, most folks haven't been in clinical spaces for a while. And so we're really excited to have you here. These talks are very specifically chosen to address core topics in internal medicine with a particular emphasis on the things that you might get called about as cross cover or as that intern on call. And we want to start to equip you early with some of those micro skills, knowing that these are skills that will continue to build over the course of the year. Okay. Every week, I will send out an email with a reminder of who should not attend ITC. So please assume that you should attend ITC. There are exceptions on every rotation, et cetera, in terms of, if you've been on a night shift, if you're post-call, all of those good things. If you have any questions about your particular situation, please don't hesitate to send me an email. Always happy to talk. Okay. In the emails that I send, I will also send the link for our intern curriculum website that's hosted as part of the internal medicine website. And on that website, we will have the schedule for ITC, as well as Brian is going to post the link to, I think it's going to be a secure YouTube channel where all of our recordings will be posted for the summer. Okay. Questions from anybody before we get started with our first speaker? You can unmute yourself, or you can put things in the chat, and I'm gonna ask Ken to look at the chat because I'm screen sharing. So Ken, is there anything that we should address right off the bat?
Nothing yet.
Okay.
I don't see anything in the chat. Yeah.
Awesome. All right. Everybody, have your caffeine ready. Have your breakfast ready. All right. This is informal. And I'm really, really, really delighted to introduce our first speaker of the summer, Dr. Paul Pottinger, who you all got to meet during orientation. As you know, Paul is one of our absolutely wonderful infectious disease specialists. He practices at the University of Washington Medical Center at the Montlake campus for the most part. He runs our antibiotic stewardship program. He is our touchstone for all things ID. And Paul is going to take it away. Is there anything I can do for you, Paul?
May I say something first?
I'm sorry. Yes, Ken. Please.
There is something posted in the chat that's very, very important.
Yes.
Paul, you need to know this too. Roxanne Hicks posted, "So excited, woohoo."
And Sylvia says,
and Sylvia says yes.
Teaching conference over Zoom. I can just go like watch in a different room, but it goes until 8.
Oh, and I'm hearing somebody unmuted. It sounds like you may be in a call room. So if you're not speaking, if you can make sure to mute yourself, that would be awesome.
Like it's a computer that's not working.
I got it, because I'm a co-host. I can keep them. The hosts can mute folks down. They may just not know how to do it. No worries. Hey, thank you guys so much. It's great to see you. I think last time we met, I didn't get to meet you. I had to do this for Anders like a day before or something. I had a COVID meeting, and so you watched me canned on TV. So this is better, because now I get to see you guys. You look awesome. This is really fun. I'm sorry it's not in person. Again, the creepiness of the COVID, but I really appreciate it. The other creepiness is that, you know, we're really lucky to have first day of ID fellowship too. So I'm in orientation with them all day over here at Harborview, but that just means that I'm not at my iMac, which means that all my slides for this talk are stuck in the iMac, and my wonderful wife is trying to get them out of the iMac right now. So the slides I built, we may get them in about a half hour if they decide to upload. But no worries, we can have a conversation. Super, I was actually talking to the new fellows about you guys yesterday and just saying what a great program we have. This year we have one person who's from the UW Medicine Training Program, that's Peter Bulger. Everybody else is from outside. All the other 7, we train 8 a year. And they're all from the East Coast, and they've all lost all their furniture. They all just moved out here, like a lot of you. And so we were talking about that. And I told them that I get to attend with you guys for a few weeks a year, which I love, and just what a great medicine program it is. And then I said, what do you guys want them to know? You just finished residency. What would you tell these first day of internship people? And they just said, tell them they're awesome. We're so glad they chose medicine. It's never been a more important time to make contributions to the profession. Never been more exciting time. And tell them to consult us early. That's the one thing that gets stuck in their craw, is if you call them at 3 p.m. for somebody who's going home at 5 p.m. So even if you're on rounds, that was my one thing I promised I'm gonna tell you. If you're on rounds, you're chatting with your attending, your senior, hey, I think we need an ID consult. Just call them right from on the spot on that little SpectraLink phone. They love being called early. Okay, so here's the agenda. What we have talked about is, last time we talked about the principles of antimicrobial stewardship and some basics, and you have Occam, you've got your guidance. So the agenda for today was to say, what do you want to talk about? I mean, I have my agenda. I have questions for you, which we can go through in a minute, but I wanted to hear from you first. And so we did put up that Google document. There have been some nice questions that have come up. Love them, really good. And if it's okay, what I thought we could do is talk about it. So here they are. Christian asked a question. Could you please discuss taking a full antibiotic allergy history? Like, what symptoms specifically would indicate a true or severe allergy? So thanks, Christian. I like that one a lot. The reason this is important, as I think you guys all know, but if you don't, you're about to realize it. We live in America, where everybody says they're allergic to penicillin. I mean, statistically speaking, coast to coast, you just talk to people, 10% of them will tell you that, hang on a second. Maybe these are the actual slides. I can't believe it. Hang on one second. That'd be too good to be true. Give me just a second, guys.
Hey everyone, while we're waiting for Paul, I appreciate, I'm seeing an extra comment question in the chat, so I'll make sure to forward that to Paul, which is great. And just for folks who may have been joining late, we do have a QR code for attendance. Why don't you just, I think it'll be easier for you to just private message me, and I will make sure to record your attendance, so thank you.
Cool. Thank you for that too. And then this is great also, and I forgot to mention this, Megan has put this in here too. If there are other questions that you guys have, you didn't happen to get time to the Google box, it's fine. Just put them into the chat and we'll see if we can get to them in time. Glad to. So for antibiotic allergies, 10% of Americans will claim to be allergic to penicillin. It's a stunning number. When is the last time an internal medicine doctor prescribed penicillin ever for anything? We use it for syphilis. It's great for the Ciph, but otherwise we just don't use it. Ken uses it because he's amazing. But basically, nobody's taking penicillin, and 10% of people say they are allergic. It causes confusion because if you hear that someone's pan-allergic, can I give them a cephalosporin? They're coming in with CAP. I want ceftriaxone. Can I do that? There's a huge antimicrobial stewardship opportunity. This is a big deal for you and the outcome of your patient. If you're taking your boards, I think you guys know this secret, right? But if you're ever given a list of antibiotics to use, and there's a beta-lactam on there, that's almost always the right answer. We love the beta-lactams. They are clean, they are non-toxic, they're usually bactericidal. So we think that these antibiotic allergies, which are usually both, are a problem. Because if 10% of people say they're allergic, only 10% of them really are. 90% of the time, that's fake news. And that doesn't mean they're lying to you. It's just their mammy told them, or this is what their pediatrician told them, or it's mythology because their sister had it, or they had a yeast infection or something. So to answer your question, yeah, just have that conversation, please. Now, I think the proper setting for this is in primary care in your continuity clinic. This is an ambulatory discussion. Whether you're Harborview, UW, whatever the setting, you're bringing somebody into your practice, meeting them for the first time, adding them from somebody else's panel. You're going through your breast cancer screening, colon cancer, hypertension, antibiotic allergies. It has to become part of our routine discussion. The time to have this discussion is usually not when they're admitted to the hospital with an infection. I appreciate you guys trying that, but it's confusing. That's really a vexing situation. We'll walk you through that process too. But the specific questions that I want to know are just the usual: who, what, where, why, etc. When did this happen? Was it more than a year ago? Was it a childhood thing in a 75-year-old person? I don't care about that. That person will outgrow that process. Almost always penicillin allergies in childhood do not persist into adulthood. Occasionally they do, but usually not. So when did it happen? Was it observed? Is it documented? If you look in our electronic medical record, is there a brilliant intern or pharmacist who said, I saw the rash erupt on this person? Or is it, nope, screening test, unobserved, never went to the hospital? Did they have to seek medical attention for this issue? Did they see a physician? If people are intubated or they get a big jab of epinephrine, they'll usually remember that. So can they even remember what the hell it was? And that's one of the biggest factors. If patients say, I don't know what it is, I think there might have been something years ago, that is totally different from Stevens-Johnson syndrome, where someone says my eyeballs peeled off and they had to sew a cow placenta to my retina. People don't usually forget that. So that is the kind of detail that we're looking for. And then the timing. If it is a rash, when did it happen in relationship to the dose? If it happened after the first dose, within hours, etc., then that is quite different from someone who says, yeah, it happened 2 weeks later. It's not that the one that happened 2 weeks later is no big deal. It's more just that, here comes the slides, it's just so fun. It's just that that's less concerning for a type 1 anaphylactic reaction, because that's what you're looking for. Here we go, I'm gonna share, and I can share my screen, right, Gabby? Here we go.
Let's share screen. Let me know if you're having any trouble with that.
Nice. And can we all just give it up, the props to my wife and apparently 20-year-old daughter who peeled herself out of bed when she's on vacation to do this. Nice. All right. Here we go. I will share screen. Thank you, guys. That is what we call a classic Zoom fail. That could be worse.
Can we hear?
All right, so that should work. Thank you.
What's being recorded?
Okay, we talked about my conflicts of interest. I don't have any financial conflicts of interest. Just interested in doing a lot of different things, as you recall. Okay, so this is just answering your questions, inpatient and outpatient. Here's Christian's question, which we're already talking about. I mean, my question to the class is usually, are you comfortable assessing penicillin allergies? When I do that with medicine attendings, ID focused or otherwise, the answer is always no, because this area is confusing. So I really appreciate that. We've talked about this, that more than 90% of those allergies are really quite bogus. And it's really important for us to deal with this. And it makes me scream with rage and anger and blows my flippant mind that this remains in 2020 a source of mythology in our profession. So these are those key things that we were just talking about, the questions that I want you to go through. In a moment, I'll show you the protocol that we're building for you in internal medicine to make this easier in your practice. This is the happy thing. So the reason that we want you to ask these questions is it allows you to pretty rapidly, either in clinic or in your inpatient practice, to put them into these buckets. Are you in the green zone? It is okay to use any penicillin or even a third generation cephalosporin. Are you in the I'm not sure zone? That sounds sketchy. I'm not happy about it. We would still give a test dose of a cephalosporin and then move ahead. Or are you in the red zone, which is you damn well better not, because that's a medical legal screw up. That would be Dress, Stevens-Johnson, TEN, etc. So there's a huge spectrum of these so-called allergies. We have really tried to work with our friends at Destination One, the EPIC people. They're super nice people. They will not be able to deliver to us what we want, which is to say this is an allergy, or this was an intolerance, this was a yeast infection, or this was anaphylaxis. They're all going to come up as allergy. That's the way it is in ORCA. That's the way it's going to be in EPIC. So it's up to you to really have these conversations. I just wanted to call out to you this nice study, which I like a lot, because we think this is true. In this particular study, which looked at hundreds of patients, if it was more than a year ago, if it was just a simple benign rash, if it was nausea, if it was yeast infection, something else, or the patient said, I don't remember, those patients got amoxicillin on the spot, 250 milligrams of amox right there, and they sat in chairs, they were observed. None of them had an allergic reaction, and 95% of them were okay. 5% would barf, because amox sometimes makes you barf when you're in chairs. On the other hand, if it was recent, if it was fresh, if it was anaphylaxis, maybe, or if the patient said, I'm too scared to do it, fine. Those patients were put into this arm where they had a penicillin skin test. The story of pre-pen, that's the trade name of the penicillin skin test, a fascinating study. It's a fascinating story. That medication went away for many years, and there were so many allergists who got mad. Can you imagine allergists getting upset? But this is what made them angry, that they didn't have this anymore, that they got together and made their own company to bring it back. So this is from doctors for doctors, and it works very, very well. If the question is about a type 1 immediate type IgE-mediated hypersensitivity reaction, the skin test is awesome, and that's exactly what we should do. This technology is available to you today at UW Medicine. On the inpatient side, yes, at Montlake. On the inpatient side at Harborview, yes, coming very soon. It's my understanding that beginning in the start of August, we will finally have dedicated FTE for an inpatient allergy consult team at HMC. His name is Dr. David Coleman. He's coming from Vandy, and he sounds like a great guy. So I think this will be a nice advance for the care of your patients over at Harborview. There she goes. Okay. So that's what I would say about that. So that's good news. But here's a nice question from Sifu. To add to Christian's question, recently at VA, we had a patient who was taking cephalexin, that's your first generation cephalosporin, without any reaction, but developed generalized itching and localized hives when he was switched to ceftriaxone because his cellulitis was worsening on cephalexin. Then he was fine with cefazolin. Does this constitute a true allergy? How common is it to have an allergy to just one ceph but not the others? I love this question. So here's the guidance we would give you for cephalosporins. Get that history. So if someone says, I think I am allergic, which may be different from this case, I think this person did not have a known history. A lot of patients do. I'm allergic to the Keflex. Was it a family history? Was it minor headaches, minor symptoms, etc.? In these cases, which is what most of those cephalosporin allergies are, we would say it's okay to use any generation of cephalosporin. I want to show you this case. It's a patient I saw in clinic last week. He was fine with me taking his photograph. This is someone who was receiving ceftriaxone because he has an intracranial infection with streptococcus. And so ceftriaxone was a good choice for him. And he took this medicine on a planned duration of 6 weeks. This rash, which you see here, erupted about 2.5 weeks in. This is your classic type 4 delayed type hypersensitivity reaction. There's no skin test for this. He had no idea he was allergic to it, etc. It just came out of the blue. So adults are sometimes cephalosporin allergic. This is obviously a miserable situation. We immediately stop the drug. He will be perfectly fine. And even though you see that peeling look on his chest, like a sunburn, that is quite different from TEN or SJS, which is a much more deep total body peeling. This is just ornery skin that's now sloughing off. And in the week or so since he took this picture, he has told us that he is getting better. So I do take ceftriaxone allergies seriously. They are real. They do happen. The issue is this, the crosswalking of one cephalosporin to another. It's confusing, it's painful, and it's not something I want you to operationalize in your practice. Let us help you with that. The chart that you see before you looks at the R group, that side chain of the cephalosporin. As you recall, the cephalosporin has its beta-lactam nucleus and then a side chain. And those side chains may be the same or similar to each other. And so I think if you'll look at this with me for a moment, we would say that if you have a patient who's getting cefazolin, where is it here? Let's see if I can find it. You guys can see it. Here it is, first generation cephalosporin. If you walk across here to say cefazolin versus ceftriaxone, There's too damn many of these things on here. Yeah, there's just nothing there. It should be perfectly fine. It's an empty cell, does not have the skull. The skull means that those two are the same. If you have an allergy to one, don't do it and walk across to the other. The scenario that you gave, Sifu, I think shows, number one, this can happen on occasion. Number two, I think it also gives us an opportunity to talk about what's going on with the cellulitis. See if I can make this go. Yeah, so here's a patient who has lower extremity cellulitis who I took care of at Montlake some years ago, presented looking like this with a cellulitis. Please notice the pillow. It didn't photograph well. This is the days before cell phones. But I had this patient's leg up on 4 pillows. At Montlake, remember, the leg has to be higher than the heart. That's what I'm trying to tell you. If you don't do that, then you don't get that lymphatic drainage. The leg's not going to get better. So at Montlake, the thickness and squishiness of the pillow, 4 or 5. And that's your job, is to do that. The foot is higher than the heart. They're watching The Price is Right or whatever they're watching. Their foot has to be up. So we did that in this case. And yet, on proper first-generation cephalosporin, the patient looked like this at day 4. Substantially worse. I think you would agree. That's not just the white balance on my camera. It was looking worse. OMG, the medicine attending, resident, and intern were super unhappy with me. What are you doing to this guy? He's getting worse. And I said, please, for God's sakes, stay the course. This is what we expect. Remember, non-purulent skin and soft tissue infection, cellulitis, it's almost always caused by strep, beta hemolytic strep, group A, group C, group G, sometimes group B, sometimes all those groups. It's usually strep, and strep is very, very susceptible to first-generation cephalosporins. So when we did that here, I said, he's going to look worse. I promise you, we're going to kill all the strep. They're going to die. They're going to barf out all of their antigens. There's going to be a more robust inflammatory response. They will paradoxically look worse and then start to look better. And indeed, that's what happened here. I'm showing you day 14. So don't be fooled or surprised. I'm not saying that's what happened here, but very common for us on ID consults to be called for cellulitis that's worsening on the first or second hospital day. We expect that. Go with the science, know that what you're looking at is almost always strep, and you're almost always fine with the first generation cephalosporin. And then I'm gonna go back. I had to shrink this down so I could see. Is that good with you guys? Let's do it this way. Ken or Gabby, if there are questions that pop up when I'm done with a case, shout it out, would you? Because I can't always see that chat box while I'm teaching.
I'm monitoring your chat, Paul. I'll let you know.
Sweet. Okay, thank you so much. So here's another question. This came from Sifu and Jordan. Basically, they had, in a meeting of the minds, the same question. How recent does your negative MRSA, MRSA, nasal swab have to be to eliminate the need to use Vanco in ventilator-associated pneumonia? Is it a distant history of positive MRSA nasal swab, bacteremia? Is that an indication for contact precautions? Does it have to be an active bacteremia and positive nasal swab? So let's deconvolute this. I thank you a lot. Really 2 different questions that are there together. This is the question. You've got somebody with bad pneumonia. Do you have to cover MRSA? That's what we've always said you got to do. We've always said that. And it is so wrong. So much of what we have taught you guys is wrong. But now we're trying to pay it forward. So the quick answer is, as you said, we only do that if their surveillance MRSA nasal swab is positive, that the nose knows. Now, the data that we base this on is not just our local experience, which is legit, studies done here at Harborview, where everybody in the unit gets a bronch. My God, I don't know how they do that, but they do it. We've been able to correlate BAL, quantitative bacterial data coming from patients with VAP, to what they have in their nose. And basically they line up really well. So that's a few hundred people here at Harborview, but now we have meta-analyses, more than 5,000 patients. The results are as you see here. Whether we categorize all cases of pneumonia or community-acquired or ventilator-associated, basically it comes down to the same thing, that NPV, the negative predictive value, is very, very reliable, assuming that your community colonization rate, normal people strutting around the world, is around 10% of nasal colonization. Here in Seattle, truth be told, we don't know that because we don't swab asymptomatic people, because that's, crazy. But if we look at people coming into a trauma center like Harborview, community-acquired people living their life, man versus fill in the blank, we swab them, 10% is probably more than we actually see in our local community here at Harborview, et cetera. At UW, it's different because people are coming from nursing homes, LTACs, Death Stars, et cetera. They have more MRSA, but in the community, this is about right. So we really do trust the negative predictive value of that nasal swab. So my overall impression is that if there's no MRSA in the nose, it's very unlikely to be in the lungs. I would never say never. You'll notice that the NPV is not 100%. It's 96, 98, 95%. So somebody has to be that 1 in 20 person that would work out to be the 96%. And I would still consider keeping that vancomycin coverage on while you wait for a BAL quantitative culture to cook. If they've got a history of MRSA personally at any point in the past, to answer your questions. And I think if it's certainly a recent infection, or if it's someone who's new to our system, we don't know them, and now they're comatose or they can't talk because they're tubed, but they have a high risk factor. And this could be someone living with opiate use disorder, et cetera, where we think that they think that they're just more likely to be chronically colonized. Then I might not, in that particular case, trust this. But generally speaking, as you can see, it's reasonable to do. There was another question too, which I actually don't think I built a slide on, I apologize, which was cooked into that previous one. Precautions. What do we do with MRSA precautions? Is it only for bacteremia? Is it any active infection? Folks, you should be on contact precautions for your patient with MRSA infection. And so if you're treating a bacteremia, if you're treating a wound, if you're treating skull osteomyelitis, if you're giving them antibiotics for MRSA, stay on precautions. Once you're done with that process and you think there's a clinical cure, the endocarditis is done, the bacteremia is cured, but they're still waiting here for a sniff and you're dealing with their diabetes or whatever, then they can indeed come out of precautions. Questions about this, please do reach out to your lovely, friendly neighborhood infection preventionist. They'll be very happy to talk to you about that as well. All good, Gabby?
Doing great. I'll make sure to interrupt you. Don't worry.
All right, sorry, I won't bug again. Thank you.
Sorry.
Okay, so that's okay. There's a question from Nick from the module. If a central or hemodialysis line blood culture turns positive before the peripheral culture, in your experience, how reliable of an indicator is that? How suggestive is it that that's probably the line? Or a similar question for the negative predictive value if it doesn't turn positive first. Overall, what stock do you put in the timing? What turns positive first? I love this. Good question, Nick. This is your question. You've got bacteremia in a patient with a central line. Is the central line the source? Or is it just an innocent bystander? And of course it turned positive because that's what the nurse used to draw the culture. It matters. It really matters. Because if your patient has a luminitis, if there's scum and crud and bacteria in a biofilm sticking to the lumen, the cavity of that line, then the line must go almost always. But if the line is clean, then you wouldn't want to lose it because changing lines is a hassle. So first of all, I would say we really do want to culture their blood appropriately. So the indication for a blood culture, do you suspect a catheter-associated bloodstream infection, a CAPC? That would be fevers, rigors, altered mental status, etc. We generally do not do this on a surveillance basis. Generally, that is against our religion, and we will string you up if you do this. There are exceptions. With our friends in oncology, try this in certain cases, and I'm not going to talk to you about that because you will not deal with that. But generally speaking, we should only culture the blood if we suspect bloodstream infection, obviously. The best way to do it in a patient with a central line is quantitative paired central and peripheral blood cultures. I'll show you what we're talking about here. To get to your question, Nick, it is acceptable to pair them central and peripheral at the same time. The issue is that there are some challenges with this, which we'll talk about. I think if you just draw one central culture, it's hard to know what to do with that. It doesn't answer this question, right? So when we talk about appropriate blood cultures, as you can see in the first bullet, what I really prefer is paired quantitative blood cultures. These are sometimes called pour plates. I'll show you why in a minute. The idea is that what we really want to understand is not just that a culture is positive, but how positive is it? If we could count the number of colonies on a plate, and if it was more than double in the central line than it is peripherally, then that strongly suggests that that is the source. Why? The greater the quantity of bugs on the plate, the greater the source was that you drew from in the first place. So my ideal fantasy would be if you have someone with a PIC, for example, I'd have you draw from the PIC in quantitative blood culture, and at the same exact time, draw from a wrist or a peripheral, and then set them up special order for quantitative. What I'm going to show you here are the photographs. This is what quantitative cultures look like. As you recall, in the bottle, it's like a little Tabasco bottle. You can't count anything. It's just a broth. It's very nutritive, and we don't get quantitative data out of that. A quantitative blood culture is that. It's a regular blood culture plus a golden top tube, not yellow, but golden. Don't ask me why. A source of confusion for our nurses. It's not their fault. But this special tube that's drawn in addition to the cultures, 5 cc's of extra blood. That blood is then mixed into hot molten agar like you can see here. And the goal is that when the cultures come up in solid phase, you can literally count them. And here you can see every one of those little Sharpie spots where each and every one of the colonies was counted by a brilliant sleepless technologist counting out those colonies. And so if you had 100 from the central line and 50 from the peripheral, it's probably going to be a central line source. The issue is that if you do them unpaired from a single blood culture, if you have more than 100 CFUs, colony forming units or colonies on the plate, that also strongly suggests that this is probably a central line source. The time to positivity question, Nick, yeah, theoretically, if you have more than 2 hours early growth from the central versus the peripheral, that also suggests that it's probably the source. But the issue there is that if they're not drawn at the same time in a patient with intermittent positivity, that's a problem. And by far the biggest confounder is the quantity. Quantity trumps everything else. It supersedes other issues because with quantity, you have a greater chance for having a bigger inoculum. So if you can get 10 cc's out of the central line, but 2 cc's from somebody's knuckle, that is not a fair comparison. And our friends in the lab will not weigh the bottles before they set them up. They just don't report this. It's been too hard for them to operationalize. So we do use that time to positivity differential as a quick and dirty trick on ID rounds. But if it really is a highly valuable source, especially hemodialysis line, try to do a paired quantitative culture, but not today. Because today is the day of the COVID. And the day of the COVID, at least at Montlake, we have these things called furloughs. Our lab technologists are enrolling furloughs. This is a service that they have cut for the moment. So at the moment, paired quantitatives are not online. We're stuck without them. It's yet another of the 10,000 untold painfulnesses of COVID-19. I'm sorry about that. Okay, so now before we go to my questions, let's go back here. I want to see if I can read the questions that you've got. Okay, I'll keep sharing my screen. We'll do it this way. Then I can go to look at the chat here myself. So I remember there was one that just came up a minute ago. What was it? From Halida, so nice. Roxanne, Gabby, oh, Megan. Here it is. Oh yeah, thanks, Megan. So the question about the timing. Yeah, this is great. So we've all heard this question, Megan. When should I get a blood culture? I really do think that in patients with sepsis or suspected sepsis, yes, you are correct. The ideal time to draw that culture is at the time that someone is shaking and baking. We think that when people have clinical fever, rigors, sweats, they are probably reacting to the antigens on the surface of that bug. In the case of gram-negative rods, as you know, that's often lipopolysaccharide and other related things from the surface, that slimy gram-negative coat, sort of like a little condom that sticks on top of every single one of those gram-negative rods. When the gram-negatives are in the bloodstream, those antigens show themselves to the immune system and you get this inflammatory response. There probably is, yes, a benefit to culturing blood at the time that somebody shakes and bakes. And I say that with the acknowledgement that may be 3:30 in the morning and your phlebotomist may not be able to get there right quick. I think operationalizing that can be a challenge, but it is something that we try to advocate for. The other thing that we absolutely advocate for, that you all know, but I'll say it out loud, is that at the time of admission, this is usually an emergency medicine question, but it could be in the hospital too. Hospital-acquired sepsis is a thing. If your patient is not already on bug juice, antibiotics, please try to grab at least one quick culture before you give them antibiotics. And I want to be extremely crystal clear about this. Yes, antibiotics, especially IV antibiotics, they really do adversely, negatively impact your ability to culture that bug from the blood or the cerebrospinal fluid or whatever sterile site you're going for. So we really like to get the cultures before you give antibiotics, but we would never wait on antibiotics to get the cultures. See what I did there? How I just screwed you because I told you to do two things at the same time, neither one of which is actually under your control, right? Phlebotomy, nursing. I think the role of the physician, especially the internal medicine R1, is to react very quickly and aggressively to cases of suspected sepsis. The diagnostic piece is huge because that gives you a lifeline to hold on to. Not today, you have to make an empirical choice, but in 48 hours from now when something grows, oh, it's so great. Okay, it's just E. coli. It was pyelonephritis. This is what we know we're dealing with. We don't need the vancomycin. So I think your job is to really help to coordinate that response. Our nurses, I think you have learned this. In general, I think they're superb and really second to none. I think they get it. And we have a whole separate sepsis nursing education outreach piece, which we are constantly tending to and trying to cultivate. But truly your job, I think, is, even if it is 3:30, is to have that conversation with the nurse and say, this is what we need to do right away. I'm going to order the antibiotics. They're coming. Our pharmacy is amazing. The antibiotics will get here soon. Please get those cultures going as quick as you can. I hope that that's clear. Okay, so Alwia, if you draw blood cultures prior to starting antibiotics, you start antibiotics. And if the patient spikes a fever, should you redraw antibiotics before redrawing the blood cultures? Yeah, thanks. Okay, so I hope that gets back. Great question. I hope that gets back to that question as well. Yeah, every time we draw blood cultures, we are phlebotomizing these patients. Super common for a patient who's fighting sepsis in our ICU for whatever reason. About a week into their admission, they will be anemic because you have sucked the blood out of these people. So iron is a precious bodily fluid. I like to keep it in our patients. But to be perfectly clear, yes, I think you have to use your judgment. If it's just been within an hour, I probably would not redraw it. You probably drew it in the first place because they were febrile. Use your judgment. I do not have, I'm sorry to say, an absolute timing cutoff. But I would simply say that especially early on when you're trying to decide what is going on here diagnostically, yeah, redrawing at the time of a fever really does make a difference. So you will never be dinged for sending blood cultures down to our lab, not by me, because we think it's actually a super important thing for you guys to be able to work with. Okay. I have questions for you if you guys don't have questions for me. Thanks,
Hey, Paul,
Alwia. Okay.
A quick question from Lucas, and I'll read it and you can decide if you want to answer now or not. Do we need to consult ID or allergy to do an allergy challenge? Can we do this on cross-cover if we feel the patient is very low risk?
So much. So and I thank you for the reminder too. I forgot to get back to that other teaching point. It's disordered because the slides weren't there. Sorry about that. So we are very fortunate to have both inpatient and outpatient allergy consultation. At the moment, the answer is please consult allergy, and we will try to operationalize that response same day. They're super busy people, amazing, brilliant, busy. So if that comes anything after early in the morning, it may not be until the next day. So ID is a great place to start because if you're giving antibiotics, they've probably got an infection. We can help with that. And we can also help you decide right on the spot whether this is so benign that we would do the test dose or a challenge right on the spot, or whether we want allergy to come in and do it. The reason I'm giving you a little bit of a hedging answer is that we have some dynamic situation with our staffing. Our current allergy ID leader is Dr. Lahari Rampur, and her last day at UW Medicine will be end of August. So we're trying to backfill that FTE. So things are a little bit disordered. Nevertheless, we think that for the reasons I was talking about before, doing these allergy tests and challenges based on the criteria I showed you, very, very safe. And we're trying to make it even easier. Yes, there's an app for that. So we now have a smartphone app that walks you through all of those questions one by one, super easy to use. The logic that was built in was created by Lahari, and the programming is built by Vidya. Vidya at Lurie is one of our antimicrobial stewardship fellows. She's great. And we are now piloting it in some of our procedural areas, interventional radiology, surgery. The next thing we're going to start doing is having the ID fellows use it. We're looking for bugs, basically. And in the next few months, we're going to roll it out to internal medicine interns to see how you like it, if you find it to be palatable, et cetera. What that will probably do is say, yep, thumbs up, you can, based on what you just entered in the iPhone app, you're good to go, give them this dose of oral amoxicillin. We're just not quite there yet because of these disordered situations. So for the moment, easy, consult ID and have that specific question, should we talk to allergy about the way that this goes or not? But I promise you, by the time you're done with this next year, this will be much easier for you to do. And Gabby, thanks for your perspective. ID consult, super quick and helpful. She's married to one of us, so she can say that. But I think it's also true. Oh, by the way, my other job is to run the ID fellowship program. So if you ever get a consult that is not helpful, I really do need to know about that. That's super important for me to hear.
I forgot to mention that, Paul.
Oh, hey, Tina.
Thank you.
Sorry, I'm doing a teach. Yeah, this is one of your chief residents. This badge will get you in if you need it. Just bring it right back to me. Sorry. Hey, you want to wave to all the interns who are here? That's a real live first, second day ID. Dr. Peter Bulger. Yeah, he used to be one of you guys, so you can grow up to be like him someday. Okay. Let me ask you some questions, if I may. Okay, so here's my question to you, interns. When would you start with empiric pip-to-the-tazo? Thank you, sir. When would you start with empiric pip-tazo plus vanco? And the answer is in Occam. I so need you to be super friendly with your Occam app because, and I know that you are, and I've asked you to do this before, but please do spend a little time looking in there. Does anybody remember where we might actually see this? Let me go to chat. NSTI, Daniel M. Ooh, if I had like a little candy that was COVID-free, I would chuck it to you. Yeah, that's right. And not just NSTI, but actually type 1 NSTI, also known as Fournier's gangrene. We're trying to get away from those patronymic or whatever they're called. But yeah, NSTI is correct. And why type 1 NSTI with Fournier's? Because Fournier's, sometimes it's thought of as scrotal or male genital NSTI. That's because that's what we can see. But remember, in Fournier's, that is not the issue. Fournier's gangrene comes from the deep, the rotting of the fat in the ischiorectal fossa. So these are GI source infections that have now erupted like a Mount St. Helens volcano coming from the deep. So when we see type 1 NSTI, it's almost never just a group A strep monomicrobial. It's almost always a mix of anaerobes, gram-negatives, enterics. Pip-tazo gets the anaerobes, gets the strep, which we need to do, and it'll even cover the Pseudomonas if we have to. So that's helpful. So type 1 NSTI, or necrotizing soft tissue infection, AKA the Fournier's. Necrotizing soft tissue infections come in 3 big classes. There's type 1, Fournier's, that's almost always in men, although I have seen it in women, but it's usually in men, coming from rotten fat in the ischiorectal fossa due to transgression of a diverticulum or some other source of GI badness that's gotten into that horrible space that then comes forward, polymicrobial. Type 2 NSTI, neck fash, that's group A strep, almost always group A strep, the flesh-eating disease that you're used to reading about or hearing about on Scrubs or whatever. So that's usually one bug to rule them all, group A strep, and if you give them penicillin or Cepha anything, you will get rid of it. For patients who are also looking septic with elaboration of LPS, if patients really look like they are going into shock, we might also give them a drug called clindamycin, because clinda will stop the production of proteins and stop toxin production. And then there's type 3, or gas gangrene. That's usually Clostridium, especially Clostridium perfringens, where patients can have huge areas of subcutaneous emphysema. In our practice here in Seattle, that's very rare. When we do see it, we typically see it in someone struggling with opioid use disorder. They are injecting or muscling, and because they're so-called works, the injection apparatus is unclean and may contain the bacillus of Clostridium perfringens, then they can actually get gas gangrene. What we see more often among injectors, which is also thankfully very rare, especially those using black tar heroin, is wound botulism. So if you have someone who's coming in with a wound associated with injection, we really do ask you to do a neurologic exam and get that good neurohistory. If they're having diplopia, if you think there are bulbar presentations, this may be wound bot. And we have not seen much of it recently. Every few years we'll get a case of wound bot. And so it's something, this is exactly one of the many things that needle exchange and safe consumption centers would instantly get rid of. It's one of the reasons we think that's really important, among many others. But anyway, do a good neuro exam when you're looking at that. And then there's the other reason that we would, anybody else, any other reason why you'd see pip-tazo plus vanco in Occam? Healthcare. Nikki gets the other piece of candy. Gabby, I hope you're taking note of who I need to send just record
Everyone
this
gets
thing
a
so I
piece
can
of
see
candy
it.
in my book.
All right, so Nikki's right. That's exactly right. So healthcare-associated intra-abdominal infection is correct. Beauteous. That's exactly the right answer. And why? Because as Nikki would be able to tell you, if we could listen to her carefully, because what we want to do in hospital-acquired MRSA, hospital-acquired intra-abdominal infection, you need to cover B-Frag, Bacteroides fragilis, the gut anaerobes. Pip/Tazo does that. You need to be able to cover patients for Pseudomonas, although it's incredibly rare for Pseudomonas to be a thing. But if they've really been in the hospital for more than a week, we worry that they get colonized with our bad gram-negative rods, our water bugs, etc. And then, yep, you've got to be able to cover them pretty aggressively if they're a carrier of MRSA. And that's often, again, people who are in and out of our system so frequently that they may have become colonized. Well played. If you do this beyond those indications, you may be right. Infectious diseases, as I gave a blessing to my fellows yesterday, they are allowed to do this. If you try to do this, we will give you 2 days to figure it out. We now have a system in which Vidya, our fellow, is looking, at least at Montlake, at all the different pips to the Tazos. And after 48 hours, she'll give you a call to have a conversation, see what you're thinking. You may be right on, and there may be an opportunity for us to narrow. As I've talked about before, the reason why we are trying to get away from Pip/Tazo is because it is a good antibiotic. I need to save it for the patients who need it, and because it is too damn broad. It will give your patient diarrhea. You will kill off every friendly member of the community of helpful germs in the intestines. So if you need to kill the anaerobes, do it. But if you don't, please don't. Okay. Another question. Oh yeah. What's it say here? When would you treat somebody with Pip/Tazo plus metronidazole? The trade name in America is Flagyl. Any ideas? While people think about that, I'm going to come back to Megan's question. If I were an antibiotic, which one would I be? We've been assigned, this is a question from John. I can tell the different personalities coming out here. Yeah, I'd be ertapenem because I'm once a day and I'm cheap. It's an old joke within the fellowship. While you guys think about this question, let me come back to Megan. How common is it for someone to become an MRSA carrier while hospitalized? So very, very rare. And we have this information because of a state law, which until recently has been the law of the land. Here in Washington State, every admission to the ICU needs to be swabbed of the nose, just the nose, for MRSA carriage. It goes back to 2010 when the Seattle Times got a Pulitzer Prize maligning Harborview for giving everybody MRSA. That was based on prior data from 10 years before, which was not favorable. By the time the article came out, Harborview, UW, we were all doing things much, much better. But they got a Pulitzer Prize. Some Republicans in Olympia said this is the way it's going to be. So we've decided to turn lemons into lemonade and actually look at this. Our current protocol, not operationalized today because of COVID, so we don't have the bandwidth in the lab, but usually in normal times, every ICU admission is swabbed in the nose, and every patient to any unit is swabbed of their wounds to figure out who's got the MRSA on admission and weekly thereafter. And so based on that data, we have this information. Conversions from nose negative to nose positive among our hospitalized ICU patients, which is a rarefied small microcosm, I suppose, of the world, extremely uncommon. It happens on occasion, to answer your question. We think the reason this is so very rare, and I apologize, I don't have the exact percentage in front of me. I think we're talking about something like 5 or 10% of the time. We think it is rare because of what you do, because of all of you, and the respiratory therapists and the dietitians and the nurses and the pharmacists and everybody gelling in and gelling and following standard precautions every time. That makes a difference. And so hospital-acquired MRSA remains a threat if we get lazy. The good news about COVID, and there's not much good news, but the one good news is I think people are really careful about hand hygiene and environmental cleansing. I think that can help take it forward this way too. So thank you for that. So nobody wants to bite on my question. When would you give Pip/Tazo plus Metro?
And Paul, while you're
and your
waiting,
silence.
While you're waiting for that, I'm just giving a heads up that we've got about 8 minutes left.
8 minutes left. Thank you. So your silence is deafening. Exactly right. You're not going to do this, right? Just like you said, pretty much never. There's generally no need to kill the anaerobes twice. It's one of my pet peeves. I think Halida can tell you when she used to rotate with us. Bacteroides, your friend, when it stays in the intestines of your patient. And so Pip/Tazo is an extremely, if you are using PIP for whatever reason, it's an extremely aggressive anaerobic drug. And when you add Metro on top of it, it's just, you've just taken away any shred of hope that they might hold on to a little B frag. You will give them the shits. They will be at high risk for C. difficile infection. And Metro in general is a useful medication, but also potentially toxic. Patients can't drink when they're on an outpatient. That's one thing because of the disulfiram reaction. But more than that, I worry about a peripheral neuropathy and patients who with longer exposures can have potentially irreversible neuropathy to their toes, their fingers in particular. So generally, and it makes people feel nauseated. So generally speaking, no need to kill them twice. That's good. And then this is my last question. So the timing looks pretty good. How long can you use meropenem without a formal ID consult? Anybody remember how we do that at UW Medicine? Remember, at UW, you do not need to call us to get meropenem. You can use it. We trust you because you are awesome and you are supervised. And Tam gets the last candied apple. Exactly right. And Thomas has this as well. So you guys got it. So for 3 days, you're good. Doesn't mean we're not going to call you before 3 days. We might reach out to say, hey, I think you're clearly on the right track or clearly not. But generally speaking, we'll have a formal ID consult get to you at 72 hours. Why? Because by then we expect your amazing microbiology tests to have started coming back. And that way we can help you try to de-escalate or not. You may have hit it right on the head and it's exactly what we're going to do. But typically that's exactly correct. There is an exception to this rule. I may not have put this into the electronic thing you guys looked at. You guys clearly did that too, so thank you. Cystic fibrosis. Patients living with CF are known to be colonized very frequently with Pseudomonas. We have a CF team that's a subdivision within pulmonary medicine. Usually we let those folks run their antibiotics because it's just a different world for them. So I'm not going to come after you if you've got a CFer. They're coming in for an exacerbation. You can handle that. As you guys probably know, we almost never admit CFers for their exacerbations. It's almost always outpatient. But if they happen to have hemoptysis as well, yes, we will indeed bring them in. Okay, that's good, really good. Really, really good, no longer than 72 hours. So before I go to my conclusory slides, what other questions have you got about anything I said or anything else? ID or medicine or politics or whatever. You get what you pay for. I'll tell you anything I think to share with you. Let's copy the slides. Yeah, totally. These will come to you. And Gabby, to make that easy, I'll convert to PDF. Try to compress it and I'll send you a link. It's still too damn big for email. Let me see if I'll get it to you anyway. Gabby, is there a place where they can get slides through the curriculum of the ITC?
Yep. So thank you, everyone, and thank you so much, Paul, and thank you for the chat. And I'll let Paul respond in the chat as I'm wrapping things up this morning. We really appreciate everybody's attention and engagement. Again, in the emails that I sent you, there's a link to the UW Medicine Intern Curriculum website, and that website is hosted on our residency website. All of our PowerPoints will be and PDF presentations will be posted there after the presentation is given, so you can access it there. And then on that site, and I will also send out a link to a secure YouTube channel that Brian Valentine is creating for us to post the recordings of our ITC sessions, which is a new thing for us this year. Previously, we've never been able to record them before, so this is new and cool, and I'm super excited we'll be able to do that for folks who are not here, or anybody who wants to review the content online. So thank you again, Paul. We really appreciate your time. I'm going to ask Paul to stop sharing screen, because what I'm going to do is then share my screen again. There's going to be one last QR code for you. Or Paul, do you have that last QR code that I sent you in your slide deck?
I do. You had me rush through my hashtags, but yeah, I'll put it up there for you guys. Okay. Thank you. This is all. This is
the second QR code. Please scan it. It will take you to a very quick 5-question evaluation. We really appreciate feedback. We try to make changes in the talks every year to make them better. and to better address the questions that you have as you start intern year. So we really appreciate your feedback. So please take the time to do it. For those of you who I know are not able to access this QR code because you're calling in from your phone, for example, folks who emailed me about attendance, I will also send this out by email now. So please take a minute to have a chance to do the evaluation. Okay. Any other questions, feel free to message me, send me an email. Again, I am really excited to see all of you in this format, and we will be back together again at 7 a.m. next week. And we are switching around the schedule just a tiny bit, but next week we will have intro to arrhythmias and actually managing arrhythmias when you're called on cross cover overnight by the fantastic Dr. Jordan Predkin, who's one of our electrophysiologists at Mount Lake. Okay, so see everybody next week. Thanks, Paul. Really appreciate your time.
Thank you, guys. Okay, sorry for the rocky start, but I appreciate what everybody's doing. I'm looking forward to meeting you guys in person, if that's ever possible. Holy cow, won't that be great? Good to see you guys. Bye.